पद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम् स्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धि
Unshare screen, please. Good evening, ladies and gentlemen. Today is a wonderful day. Today is once again Secrets of Neurology. As we know, it's a knowledge feast for all neurologists. Ladies and gentlemen, we are very proudly happy to inform you that this is the longest running educational web series. And today is exactly year 1. And this is episode 13. This whole journey has been because of our mentors, because of our patrons. We started from DMC Ludhiana, JIPMER, Madras Medical College, Bombay Hospital, NIMHANS, CM Civil Law, IPGMER, Calcutta, Trivandrum Medical College, Travancore Medical College, Antha Medical College, PGI Chandigarh, Stanley Medical College, Chennai, KIMS Hyderabad, and today's anniversary special is confirming a very, very warm welcome to our program director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan. A very, very warm welcome to the expert neurologist from Mumbai. And we intend to close it by 9:40. An honor and privilege for me to introduce Dr. Sudhir Shah, Professor and Head Department of NHL MMC SVPI MSR, Ahmedabad. Sir is also Director of Neuroscience, Sterling Hospital, Ahmedabad. Many rewards and accolades to Sir's credit because of his work in the field of science, research, and contribution to community at large. He was conferred Padam Shri in 2016. He is also recipient of prestigious Dr. B.C. Roy Award, and he is also recipient of UN Award. Sir, may I invite you today to do a very auspicious work today. Over to you, sir.
Very much, Dr. Manoj, for the kind introduction and the invite. As you rightly mentioned, this is really an auspicious day in the journey of Secrets of Neurology webinar series. And today we have completed 1 year, and that's why it's the 13th episode. And to commemorate this special episode, we have a first wonderful task to finish, and that is to unveil the book edited by Dr. Lakshmi, Dr. Mukundan, and Dr. Rajesh. And I request Dr. Haley to kindly play the video. Thank you. Thank you very much, Dr. Heli. It is with immense pleasure that I inaugurate this book, Immune-Mediated Neurological Disorders, edited by Dr. Lakshmi Narasimhan Ranganathan, Dr. Mukundan Krishnan, and Dr. Rajesh Shankar Iyer. The multi-layered immune architecture in our body provides exemplary defense against the invisible microbes. We know that very well. And in the current scenario of rapidly expanding information in the field of autoimmunity in neurology, this book, Immune-Mediated Neurological Disorders, is very, very valuable in organizing the vast information, and I think it is the need of the hour. There are very few books of autoimmunity in neurology currently that are available, which are so clear, so comprehensive, and so complete. I had a pleasure to write forward of the book, and therefore I have gone through the book, and I think it is very, very interesting. I'm sure right from PG students to the practicing young neurologists and senior people, it will be very, very immensely useful. The book takes care of autoimmune evaluation of the neural antibodies, autoimmune dementia, demyelinating disorders, autoimmune epilepsies, movement disorders, myelopathies, neuropathies, and whatnot. So once again, I congratulate all the editors and all the authors who have an immense vision in writing the book, taking so much pain. And I once again reiterate that this book is for one and all, and I'm sure we'll have a wonderful reading of this book. So please wait for the book to come to you. With that, I invite my friend, Professor Lakshmi, to say a few words on this occasion.
Thank you. Sir has always been, for me, Professor Sudhir Shah is always an inspiration. And once when I went there, he asked, he only inspired us to write this book on the Indian context of immune-mediated disorders. And my humble thanks and salutations to him. And when I requested him for a foreword, he immediately agreed to get a foreword from such a great person who is, it's a great honor for all the three of us, and my humble thanks to him. And secondly, at the end of this 1 year, my journey guided by my mentor, Professor Sudhir Shah, was extraordinarily enjoyable. And every time he promptly reminds me of how things, and even in choosing the right kind of people for right kind of cases and all. So he was very meticulous in everything. Once people who move with him will know how perfect he is in the art of neurology. My greatest salutations to him. My second, I sincerely thank all the 12 medical colleges which have contributed for this, and now for this, making this Neurological Secrets a great success. May I now request the Professor Sudhir Shah to go through today's proceedings. Thank you so much.
Can we have the slide of all those 12 medical colleges who have contributed with the topics if you have?
And the video.
Friends, first of all, I would like to thank all the viewers, all the participants who have been the great source of our inspiration and kind of motivation to continue this program. When we started this program, we were not very sure how this will be taken up, but actually all the medical students from DM, DNB, and apart from them, many of the budding neurologists, practicing neurologists, seniors, everybody is blessed by their presence, their comments, their participation, and most important is that all those 12 medical colleges. May I have the slide? I want to thank them.
Sir, the slide has been
mentioned. No problem. As has been mentioned, it started with alma mater of Dr. Lakshmi, that is Madras Medical College, and then went on to uh, another from Bangalore, from Deepmed, to Hyderabad, Kale, then Satish from Mumbai, then Ludhiana CMC, and we had some from Kolkata, and last we had from Vivek Lal and the other one from the Telangana. So we had a wonderful participation of medical colleges, and I must congratulate all the students who presented their cases very nicely, and equally or rather more important, the dissection of the case is done by the assistant professor, the associate professor, the localization, and then experts comments by the professors. What a great feast it was all the way for 12 episodes. And all of us, we learned neurology, and we saw some of the rarest cases, which sometimes we see only once in lifetime, like the one Whipple's case. So I must congratulate all of them. I must thank them heartily. I must thank Professor Lakshmi Nanganathan, who is really a very sincere, hardworking, very worthy gentleman who has taken large role in actually pushing the whole program every time. And as I mentioned, I must thank all of the viewers, and also, last but not the least, Intas Rose and Reason for the logistic help. With that, I would like to invite Professor Sangeeta Rawat and her team for presenting today's case. And Dr. Healy, may I have a chance to introduce them briefly?
Yes. Sir, we are having one video, especially on the 12 series.
Oh, great. Go ahead. I wanted that. Yes. Wonderful. As you can see, there are all stalwarts of neurology across India, and we had a wonderful feedback. And to honestly tell you that we had viewers from so many countries, including UK, Canada, Italy, France, Thailand, Sri Lanka, Nepal, and so many other nearby countries, including Pakistan. So I must thank all the speakers and professors and students who have given a great contribution in bringing this webinar series to this great level. And therefore, we have decided to continue this for the several more episodes, with, of course, hope that you will all continue to pour your interest and inspire us more and more. Thank you very much. The Dr. Rishikesh Joshi. Today it is the turn of AM Hospital, Mumbai, St. James Medical College, where the professor head is my colleague, Dr. Sangeeta Rawat. And it is very interesting to mention here that we were getting together in KM today. So, may I have the previous slide? Rishikesh Joshi, senior resident, will, I think, he will present the case. And next slide. Shruti Agrawal, who is the assistant professor of GS Medical College and KM Hospitals. She will give localization and some further discussion. Next slide, please. Akash Cheda, assistant professor, who will give further discussion and dissect the case. Next slide, please, including anatomical details. Dr. Neeraj Jain, additional professor of neurology and consultant neurologist at Apollo and Fortis London Hospital, who is a MD DNB, DM DNB, has a fellowship in neuromuscular disease in Paris. He has 10 international, 2 national publications, and 6 posters. He had traveling fellowship bursary for AMC 2009 Seoul, and his fields of interest are epilepsy, EEG, and neuromuscular disease. He will take this case further. Next slide, please. And we have our movement disorder specialists. So, as you know, the hierarchy is like this: the case is presented by a resident, and then the assistant professors and associate professors, they go on dissecting from etiology, from localization, from anatomical aspects, and then special remarks are done by other super specialists. Pankaj is a dear friend, he's a clinical neurologist and head movement disorder clinic in charge, and also DDS program in charge at Global Hospital, Mumbai. The honorary teaching faculty again at St. James Medical College, KM Hospital. Is mentored by Professor V.S. Singhal. His fellowship training in Pacific Parkinson's Research Center at Vancouver, Canada for 2.5 years under Professor John Stossel. He founded and established movement disorders clinic and DBS program at Global Hospitals, Mumbai. His primary interests are neurology, stroke, movement disorders, neuromedical care, and certified trainer for neurocritical care. Double-level certificate in yes. He has several papers and publications. He has several talks, and he is a reviewer of so many national and international journals. And of course, he is a governing council member of the Pediatric MDS Society. Okay, next slide, please. And Dr. Sangeeta Rawat, a very able leader and the person who takes all people together and makes a great team. She made a great team at KIMS, again made a great team at Global. The professor and head Department of Neurology, University Hospital KM Hospital, Mumbai, consultant neurologist, Global Hospital, Mumbai. The chief epileptologist at Comprehensive Epilepsy Care Center at KM Hospital and Global Hospital. As you know, in the Western India, it is one of the most busy centers. And I am happy to tell that she and her team have operated so many of our cases from my center as well as from all over Gujarat and other areas. I think her number is more than 600 or something of epilepsy surgery. She had an epilepsy fellowship at Melbourne, Australia in 1998. She's running a highly successful epilepsy surgery program. As I mentioned, more than 600 cases. And she's the next president of Maharashtra Association of Neurologists. She's vice president of Indian Epilepsy Association Bombay chapter, and she has published over 60 articles in national and international journals. Next slide, please. Okay, so with that, I would now straightaway request Professor Sangeeta to take over, introduce the team, and start the proceedings. Thank you very much.
Yeah, good evening, everyone. And Thank you very much, Dr. Sudesha Bhai and Dr. Lakshmi Narasimha for inviting our department to present some interesting case here. So I and my team have put together some, apart from the one case, the several other cases to which are the learning points. And because I know that this is not only one case discussion, it's a teaching forum for the junior neurologist. So we have also included some theoretical thing and some interesting videos also, and I'm sure you all would like it. And also I thank INTAS for giving us this support to have this program. And also special congratulations to Lakshmi for that book, because our case is also similar to that. So I think we will start with our first case presentation by my resident, Dr. Rishikesh Joshi. Rishikesh, you can share the screen.
Yes, ma'am. Yes. Are my slides visible?
Not yet. Yeah, they're visible now.
Good evening. I'm Dr. Rishikesh Joshi. I'm a second-year resident at the Department of Neurology at KM Hospital, Mumbai. Today we'll be discussing an interesting case. We have a 16-year-old girl who presented to us with 1 week history of low-grade fever, multiple episodes of left focal motor unaware seizures, and 1 episode of bilateral tonic-clonic seizures. Along with that, she also had some peculiar episodes of going round and round in circles. And her father noticed that she had behavioral changes. She had become lethargic and irritable. So this is how she had presented to our OPD. She used to have these rotatory episodes for the past 2 days. Her awareness was impaired during the episode. 2 to 3 episodes of such semiology were present throughout the day, and the duration will be typically 1 to 2 minutes. If not physically restrained, she would either bump into objects and thereby injure herself. Now let us go back into some of her past history, which is significant. She had a normal birth and development until the age of 5 years of age, when she had her first seizure. The seizures were multiple left focal onset motor unaware seizures and bilateral tonic-clonic. For this, she was admitted at the pediatric department at JJ Hospital. Her sensorium was altered for 7 days, which improved. However, it left persistent language difficulty. She was able
We can't hear you, Rishikesh.
And I think he lost his connection.
Yeah. Shruti, can you call him up and say?
Yes, ma'am. His number is busy, ma'am.
I think the screen share is also stopped. I think he must be figuring out. Just tell Santosh to help him.
Yes.
Well done.
Unless you have a small glitch or two here and there, it doesn't feel like a real presentation.
So, sorry.
No, back, one slide back. Yeah, here.
So, sorry for the glitch. So now that the patient had presented to us with these peculiar episodes and low-grade fever and multiple episodes of seizures, she had a significant past history. So till the age of 5 years, she had a normal birth and development when she had a first seizure. There were multiple left focal onset motor unaware seizures and bilateral tonic-clonic seizure, for which she was admitted to the pediatric department at JJ Hospital. Her sensorium was altered for 7 days. It improved with persistent language difficulty. She was able to understand the spoken words, but wasn't able to generate any word output. She was thought to have epileptic encephalopathy, and a working diagnosis was Landau-Kleffner syndrome. She was evaluated in detail. The MRI brain at that time, 1.5 Tesla, was normal. The CSF analysis showed a protein of 22 milligram per deciliter, sugars were 55, and there were no cells. The corresponding EEG, however, is not available. She was treated with anti-seizure medication, injection methylprednisolone, and IV antibiotics. The speech improved completely after 6 weeks of treatment. The only residual sequelae, however, were infrequent left focal motor unaware seizures with occasional bilateral tonic-clonic seizures. She did not have any residual psychiatric or behavioral sequelae. She was continued on tablet oxcarbazepine 150 mg BD and clobazam 10 mg HS. She came to us at the age of 8 years for intermittent seizures. Interictal EEG was suggestive of occasional generalized spike and wave discharges. So we optimized her anti-seizure medication to oxcarbazepine 300 mg BD and tablet clobazam 10 mg BD. After which she achieved better seizure control and only one focal seizure per 6 months was the frequency. She did not have any seizures for the past year before she developed the current complaints. Other than that, she was an average student in school and had recently passed her SSC examination. Menstrual history, she had menarche at 12 years and regular 28-day cycles. Her sleep, appetite and bowel bladder habits were normal. Are the slides moving, ma'am?
Yes.
Okay.
Yes.
She did not have any.
Is very good.
She did not have any history of preceding fever, a headache, a rash, or chills with the fever. No history of any forgetfulness or missing ways. She did not have any motor or sensory complaints and did not have any signs of cranial nerve involvement either. No history was suggestive of myoclonic jerks and no bowel bladder complaints either. On day 5 of admission, she developed transient perioral left upper limb dyskinesias with autonomic dysfunction in the form of diaphoresis, and her heart rate and blood pressure would fluctuate very widely. Examination-wise, her built-in nutrition was average. She had a pulse rate of 78 per minute and blood pressure 110 by 80. However, it was fluctuating. Interictally, she was responding to simple verbal commands, but was not cooperative for a detailed evaluation. Apart from ataxic gait, she did not have any remarkable findings on examination either.
No caller.
We investigated her. A routine blood workup, a complete blood count, renal function, liver function, and electrolytes are normal. She underwent an MRI brain with contrast, which was also normal. The lumbar puncture was done. Proteins were 18 milligram per deciliter, glucose was 78, and a parallel blood sugar 118. She total cell count was 3. All were lymphocytes. She underwent a bedside EEG, which was suggestive of some right hemispheric slowing. I would request my senior Dr. Shruti Agrawal to further dissect the case and give us the differential diagnosis. Thank you. Sorry for the technical.
It went well. Now, Shruti, you start sharing the screen.
Yes. Is my screen visible?
Yes, Shruti.
Good evening, everyone. I am Dr. Shruti Agrawal. I am assistant professor, also fellow in epilepsy at CGS Medical College in KEM Hospital. And today I'll be taking you to the process of analysis of this case, and we'll be discussing the differential diagnosis. I have divided the analysis of the case into two parts: what happened at 5 years of age and what happened at 16 years of age. So at 5 years of age, the summary says that she had afebrile seizures, less focal motor, as well as bilateral tonic-clonic seizures with altered sensorium and language disturbance. This language disturbance persisted for around 6 weeks, and she recovered after that. Normal MRI and CSF at that time, and she was treated with steroids and anti-seizure medications. She improved in terms of seizure control and language, and she had fairly average intellectual functioning after that, such that she could clear her secondary school exam. Now, the differential diagnosis in this case at this point remained with the summary of afebrile encephalitis or encephalopathy without any structural lesions with seizures and protracted language disturbance. So we could think of 3 differentials at this time: whether that episode was an encephalitis, whether it was epileptic encephalopathy because patient had presented with seizures, or whether it was a status epilepticus and then followed by a non-convulsive status epilepticus, including the aphasia, which lasted for 6 weeks. So let us get into the details of each one of them and dissect to see what fits into our case. So encephalitis, it is the most common presentation in encephalitis is seizures, altered sensorium. So the common causes of encephalitis, most of the times it is infectious, but the other causes are immune, and we'll go through some of the other causes as well. Amongst the infections, viral infections are the most common causes of encephalitis, like herpes simplex virus, enterovirus, mumps, EBV, and even Chandipura virus, which is present with an acute encephalitis episode. And tuberculosis always remains on the card, being in India. Bacterial fungal are the rare causes. Immune-mediated encephalitis includes demyelinating diseases like EDEM and MOG-associated disease. Autoimmune encephalitis is one of the differentials, and NMDA is the most common autoimmune encephalitis in pediatric age group. CNS vasculitis could also have been one of the differentials. Others include drugs, toxins, malignancies, and the rare ones like inborn errors of metabolism. Now, in our case, the likelihood of encephalitis, what were the points favoring viral encephalitis? It is the most common diagnosis with presentation of seizures and altered sensorium. History of fever may have been missed, and possible sequelae of epilepsy is described in encephalitis. And in our patient, she had very occasional seizures, 1 per 6 months after that for the next 11 years. The points favoring against viral encephalitis include there was no definite history of fever. The CSF and MRI at that time were normal, and she responded to steroids. So these points are against viral encephalitis. In our case, no history of fever and good response to steroids in terms of seizure control. Even the language had improved. This favor immune etiology over infectious etiology at that time, if we consider the encephalitis. Now, the second differential is epileptic encephalopathy. International Encephalitis Consortium has given a simplified diagnostic criteria for what is the definition of encephalitis, what is encephalopathy. Similarly, International League Against Epilepsy This commission has defined epileptic encephalopathy in 2010 as it embodies the notion that the epileptic activity itself may contribute to severe cognitive and behavioral impairments above and beyond what might be expected from the underlying pathology alone, and that these might worsen over time. So bad epilepsy is the prerequisite to call it as epileptic encephalopathy. Now, epileptic encephalopathy is a process whereby epileptic activity in the form of frequent seizures and or interictal epileptiform discharges, they adversely affect the brain function. We'll go a little bit into details of the mechanisms of epileptic encephalopathy, this being not just the case presentation and a teaching forum. For the benefit of the students, I'll go a little bit into more detail. Potential mechanisms for epileptic encephalopathy, they include changes in the cellular excitability due to altered ratios of ion channel subunits, synaptic reorganization, neurogenesis, and apoptosis. Another mechanism described is disruption of the integrity of neuronal networks. Common epileptic encephalopathies in childhood at this age include Lennox-Gastaut, Landau-Kleffner syndrome, Dravet syndrome, and myoclonic aesthetic epilepsy. A word about Landau-Kleffner, because this was considered as one of the diagnoses at that time in this child. Landau-Kleffner, by definition, is an epileptic encephalopathy characterized by acquired verbal auditory aphasia with or without seizure. It is associated with bitemporal or parieto-occipital discharges. It may be associated with continuous or almost continuous spike and wave discharges during slow wave sleep. The treatment includes IVIG and hydrosteroids. Adequate and early management may avoid language and cognitive deterioration. 27.5% they completely recover from the language deficits, and remaining patients continue to have language deficits and or cognitive disturbances of different degrees. In our case, as described into the records and as described by the relatives, comprehension was preserved in this patient at that age, but she couldn't speak meaningful sentences. But in Landau-Kleffner, by definition, it has to be acquired verbal auditory aphasia, meaning the comprehension should be gone. So this was unlikely to be Landau-Kleffner. When she came to us at 8 years of age, we changed the diagnosis, and although the treatment was continued with the optimization of anti-seizure medication. The third diagnosis, the third differential at that time could have been a non-convulsive status epilepticus after a period of altered sensorium. Unfortunately, we don't have the EEG from that time, so we don't know what was going on for those 7 days of altered sensorium. But after that, when the patient had language disturbances for 6 weeks, there's something called as aphasic non-convulsive status epilepticus described. So in the non-convulsive status epilepticus, aphasia could be one of the manifestations. Non-convulsive, it can present abruptly or subacute in onset, and the recovery is with anti-seizure medications. It can have an early recovery or can have a protracted course. Both are reported. In this patient, this still remains a possibility because patient definitely recovered it with anti-seizure medication. Now coming to the part 2, what happened at 16 years of age. The summary at 16 years includes that on a background of fairly well-controlled seizures and preserved cognition, she had a sudden increase in the frequency of seizures. There was a new phenomenology seen of rotatory movements. There were behavioral changes, oral dyskinesias, left upper limb dyskinesias, autonomic disturbance. The MRI and CSF done again were normal, and EEG, we'll talk about it in a while. Now, the questions at this point that we should ask ourselves are, what are these new rotatory episodes? And why there is a sudden increase in the frequency of seizures when for all the 11 years on 2 drugs she was well controlled? The new features like psychiatric, autonomic, and movement disorders have added to the complexity of this disorder. Whether this episode is related or unrelated to the previous pathology remains a question at this point. So coming to the EEG here, as you can see, there is a continuous right hemispheric, predominantly frontocentral, delta brush slowing, delta range slowing, along with superimposed fast activity, which is the extreme delta brush pattern. So we did the APE score at this time. We'll come to the details of the APE score later. The score was 9 out of 15, and more than 4 is significant for autoimmune encephalitis. That is when, after seeing the EEG clinical picture at the age of 16 years and the 8 scores, we decided to send the autoimmune panel. So the serum and CSF anti-NMDA antibodies turned out to be strongly positive. CT abdomen pelvis was done to rule out ovarian teratomas, and there was none. So she presented initially at the age of 5 years with seizures, query status epilepticus, altered consciousness, and language impairment. And then after a long period of quiescence of 11 years, she presented with psychiatric symptoms, autonomic dysfunction, and complex movement disorders. So the entire varied manifestations, they fit into one diagnosis of autoimmune encephalitis at this stage. The final diagnosis was anti-NMDA receptor encephalitis. Now coming to these rotatory movements, this still remains unanswered, that what were these rotatory spells. So they were quite stereotypic left-sided head turn first, and then the entire body was turning to the left side, and she was rotating around herself with impaired awareness lasting for 1 to 2 minutes, and 2 to 3 such episodes happened per day. It is very difficult to distinguish these complex movement disorders, whether it is movement disorder or seizures, and it is a clinical and therapeutic challenge to differentiate between the two. Now coming to these episodes, if you see carefully, the head is turning first to the left side, then the entire body, and she's rotating around herself. The father is trying to control her. She is unaware of these episodes, and they stop after 1 to 2 minutes. Now, do these gyratory spells, they represent epilepsy or movement disorder? Let us see what are the points favoring each. Points favoring epilepsy include that there was an extreme delta brush pattern on EEG contralateral to the direction of gyration. She was rotating towards the left side, and the delta brush pattern was more in the right hemisphere. She had impaired awareness during the episode, and patient is a known case of epilepsy already, and gyratory events have been earlier described in epilepsy, coming from the frontal and temporal lobes predominantly. So these points favor epilepsy. But what are the points favoring movement disorder? The thing that it is a rotatory movement first place, then it is associated with other dyskinesias like oral and left upper limb dyskinesias that she had, and they were not controlled with the multiple anti-epileptics. These points favor movement disorder, it being a movement disorder. Now, are these rotatory spells stereotypy? What is stereotypy? First of all, stereotypy is very commonly seen in NMDA encephalitis. Usually they are prolonged episodes and they may last for hours. Awareness is preserved during this episode and the EEG is normal. Now, the points against stereotypy in this case are all gyratory episodes lasted for 1 to 2 minutes only, with abrupt onset and abrupt offset. This patient had 5 to 6 episodes per day. The awareness was impaired and EEG was abnormal. So this is unlikely to be a stereotypy. So what exactly it is, it still remains open. It is an open debate whether it is an epilepsy or a movement disorder. But we think that it should be epilepsy, considering the contralateral delta brush pattern on the EEG, impaired awareness during these episodes, and the overall frequency and the presentation of NMDA encephalitis with movement disorder, epilepsy, both are common in NMDA, but given the clinical scenario, EEG epilepsy seems more likely, but it still remains an open debate. Unfortunately, we could not record these rotatory movements in the EEG. So ICSEL EEG we could not record because she had to be restrained and sedated to control these episodes. Coming to the treatment that was given to this patient, just to complete the case, anti-seizure medications were first tried, like IV fosphenytoin, IV levetiracetam, and an add-on with lacosamide and perampanel. And due to recurrent seizures without improvement in the sensorium, we started her on midazolam infusion, and we escalated to thiopental ketamine, which were cyclically weaned off after achieving burst suppression pattern. Immunotherapy, including injectable methylprednisolone, and then followed by IVIG and rituximab, were all given over the time. But unfortunately, on day 40, due to complications like VAP, she succumbed to the illness despite vigilant ICU management. The takeaway points from this case are NMDA receptor encephalitis has relapses in about 24% of the cases. The first major relapse came after a prolonged quiescence of 11 years in our case. The mean duration of relapse reported is around 2 years, but variable durations have been reported from 0.5 years to 10 years even. Autoimmune encephalitis can go undiagnosed for many years and with relevant clinical scenario, irrespective of the duration of illness, irrespective of the confirmation of the autoimmunity at the first episode, autoimmune encephalitis should always be suspected in a relevant clinical scenario like this. Thank you. I would request Dr. Akash sir now to take over from here.
Excellent. I thought that was a fantastic presentation, Shruti.
Thank you.
Good evening. So following a very nice presentation by Dr. Shruti, in which she has excellently presented our case, which was anti-NMDR encephalitis, we move forward to the discussion on this broad and complex topic, which is still evolving. And I would like to talk on gyratory seizures, gyratory events, which we saw in our case.
Akash, do full screen. Yeah, that's fine.
So I'm Dr. Akash Chheda. I'm lecturer at KEM Hospital under Dr. Rawat. So about gyratory events, gyratory seizures, it was Erastus in 1551 who had described a lady post head injury where he noticed that she would turn around in circles, many circles at a time with impaired awareness. And this was cited by Ferrello and Mahendale in 1983. So what are these gyratory seizures? They have very rarely been described in the literature. They are also known as rotatory, circling, volvular seizures and Zwangkreisen in German, which means rotation around self. It was initially thought to be associated with generalized epilepsy, but now we know that they are described in frontal, temporal, even extratemporal focals, and even thalamus. To define gyratory seizure, it is rotation of the patient on his own body axis by 180 or 360 degree. So minimum of 180, but they can go round and round. That is more than 360 degree is possible in rotatory seizure. It is linked to basal ganglia and its circuitry. So there were two models which were proposed. So it is unilateral activation of striatum, which causes ipsilateral GABAergic inhibition of the pallidum, thereby causing disinhibition of the excitatory thalamocortical influence on the SMA, that is supplementary motor area, resulting into contralateral motor activity and circling in the opposite direction. Also, asymmetric activation of basal ganglia can trigger the same circuit, resulting in contralateral SMA activation and circling in the opposite direction. So direction of rotation during the gyratory seizure is very important to lateralize the seizure onset zone. Forced versive head movement before rotation points to a contralateral lobe as a seizure onset zone. Whereas when there is no preceding head movement, it is the ipsilateral brain area which is responsible for the seizure onset. In our case, there was a forced head version and then there was a trunk version to left. Also, we had a corresponding contralateral delta rhythm on EEG, which points to a right mesial frontal focus on epilepsy. Usually it is contralateral frontal and ipsilateral temporal, which is described in the literature for gyratory seizure. So can gyratory seizures occur in anti-NMDR encephalitis? Yes, we have just seen them. So these gyratory events have not yet been described in anti-NMDR encephalitis. We published this case in Seizure, and the highlights of this case were that gyratory events are novel manifestation of anti-NMDR encephalitis. It highlights the arduous task of clinically distinguishing epilepsy and mixed movement disorders, which are very well seen in anti-NMDR. This is very important as it has got therapeutic implication. If it is epilepsy, it has to be treated by anti-seizure. We need to achieve burst suppression if it is continuous. Plus, we also need to know that when to stop treating those gyratory events if they are not a part of seizure, because they can be motor perseveration stereotypy. In that case, EEG would be normal and we may not treat them aggressively as non-convulsive status. the case highlights that protracted disease course can occur with a relapse after many years of quiescence, like in our case, and also consider anti-NMDR encephalitis in chronic epilepsy when a breakthrough event ensues with new onset drug refractoriness, altered mental status, dysautonomia, and complex movement disorder, as was seen in this case. So now we move to other cases in the same spectrum, and from our hospital we have these two prototype cases which I'll show. Many will follow in the future discussion. So there was a young lady who had ovarian teratoma, proven NMDA encephalitis patient with mixed movement disorder. She would have this orofacial and lingual dyskinesia and hand stereotypy. And then there is another child with chorioathetoid movements and ataxia. So I'd like to show the video. So on the right, we could see the finger flapping stereotypy, the hand flapping stereotypy. And when we zoom, we could see this orofacial lingual dyskinesia plus eyebrow raising. So this could be a part of dyskinesia. It could be a seizure. But looking at the semiology, it looks more like a rhythmic, tremulous, more of a dyskinetic movement rather than seizure. Even myarrhythmia, catatonia has been described in NMDR encephalitis. Even after removal of teratoma, she did not improve. She had also received IVIG with teratoma excision and then was referred to us with persistence of her encephalopathy and movement disorder, at which point she received plasma exchange, and this was her post-exchange video in which she was having a prolonged course in the hospital. She has developed wasting of her hand muscles. She has developed this tremor which we attributed to critical illness, myoneuropathy. But the point in this case was that you cannot stop treating anti-NMDR encephalitis. You have to hit hard, you have to hit fast, and you have to escalate your immune therapy to whatever level possible. So this is another patient. He's a child who had subacute onset encephalopathy, regression with this abnormal posturing of both his limbs. He would have this constant movement of his body, chorioathetoid kind of movement with dystonic posturing. So this mixed movement disorder is very classical for anti-NMDR encephalitis. He came early to us. We were early in diagnosing anti-NMDR. We treated him with IVIG and he showed good improvement over 3 weeks. So variations of movement disorder in anti-NMDR is very well known. Chorioathetoid movements are seen in children less than 10 years, whereas catatonia is seen in patients more than 10 years of age. Also, movement disorders in children, it is difficult to distinguish them from basal ganglia encephalitis and Sydenham's chorea. But this paper highlights that stereotypies and perseveration are more commonly seen in anti-NMDR encephalitis, whereas their absence and presence of akinesia and tremor points towards basal ganglia encephalitis. Chorea and dystonia do not help in distinguishing between the two. So it is an evolving field. Diagnose early, treat relentlessly. That is the message which we have to give from these cases. Movement disorder expert will take you through the entire spectrum further. Thank you. Here onwards, I hand over to Dr. Neeraj Jain sir for further elaboration on the topic of autoimmune encephalitis. Thank you.
Very good, Akash, I think. Let's now hear more on theoretical part from Neeraj.
So thank you very much for giving me this opportunity. So I'll be taking out some discussion on the recent update and some learning points across the spectrum of autoimmune encephalitis. So to introduce the broad topic of autoimmune encephalopathies, there are two broad categories of disorders. First, in which the antibody is directed against the cell surface antigens, which are classically known as autoimmune encephalitis. And then there is a group in which the encephalitis is associated with intracellular antigens, which usually are paraneoplastic. And we need to know this because of the different prognosis and different treatment implications. The triggering factors in the genesis of this autoimmune encephalitis or paraneoplastic syndrome can be cancers, some drugs, checkpoint inhibitors, which are usually given in treatment of some of the cancers like lung cancer, Then infections, especially in NMDRA and autoimmune encephalitis, sometimes they can be preceded by viral or bacterial infection. And then there are some HLA genes which makes you prone for getting certain particular autoimmune encephalitis. So broadly distinguishing between the paraneoplastic syndromes and autoimmune encephalitis, the onset of paraneoplastic syndrome usually is subacute, whereas autoimmune encephalitis can be acute in some cases, as we have seen. Multifocal involvement is frequent in paraneoplastic syndromes, whereas it is rare in autoimmune encephalitis. The most frequent associated antibodies in paraneoplastic syndrome, which are intracellular antigens, is U and U, which is common in adults. And among the autoimmune encephalitis, NMDAR, LGI1 is most common in adults, and in children, MOG and NMDAR receptor encephalitis is common. In the paraneoplastic syndrome, the antibodies are non-pathogenic, whereas in autoimmune encephalitis, the antibodies are pathogenic, and that's why immune-mediated therapy works very well. The cancer association is very strong in paraneoplastic syndrome, where it is low or mild. It depends on the antibody type in autoimmune encephalitis. The typical cancers in paraneoplastic syndrome are small cell lung carcinoma, non-small cell lung carcinoma, breast, ovary. So basically some solid tumors, whereas in autoimmune encephalitis is more associated with teratoma, thymoma, or small cell lung cancer. The pathology slightly is different. The T cell infiltration is predominant in paraneoplastic syndromes, whereas it is more of a B cell and plasma cells involvement in autoimmune encephalitis. So autoimmune encephalitis, definition-wise, there is a clinical triad of memory, behavioral changes with seizures, usually subacute onset. There can be known or unknown antibodies, and usually they are responsive to immunotherapy. So broadly categorizing this group of autoimmune encephalitis, the salient feature of this surface antibody syndromes, they can have wide age range of patients, can be in young adult, adolescent, and children. 70 to 80% of patients have substantial or full recovery after immunotherapy and tumor treatment when present. So that's why it is very important to pick up at the right time. So some of the key syndromes I'll just discuss. So NMDA receptor encephalitis we have already seen. Usually around 50% of female patients have ovarian teratoma, and we should search for it hard. And even if we are not able to find it, we should follow up the patient closely for up to 4 to 5 years. LGI1 we will be discussing, usually characterized by the classical faciobrachial dystonic seizures and hyponatremia. And less than 10% of patients are associated with breast, lymphoma, thymoma, or thyroid cancers. Caspr-2 antibody syndrome, usually in older adults, associated with sleep disorders, peripheral nerve hyperexcitability, myokemia, ataxia. Less than 5% of these patients are associated with various tumors. Then GABA A and GABA B receptor encephalitis, usually seizure is one of the common presentation. AMPA receptor encephalitis, usually common in older adults, amnesia and other psychiatric symptoms are common. Then this new syndrome, DPPX antibody syndrome, usually GI symptoms are associated with other neurological symptoms like myoclonus and hyperexcitability. Less than 10% of patients do have lymphoma. Now, the diagnostic criteria given in Lancet Neurology journal article by Gross F in 2016, we should always take into consideration whenever we are diagnosing this rare syndrome. So, a subacute onset, rapid progression of less than 3 months of working memory deficit, seizures or psychiatric symptom, which suggest involvement of the limbic system, that is a clinical criteria. Then radiologically, they should have bilateral brain abnormalities on MRI, restricted usually to temporal lobes, at least in the initial stage. And at least one of the following: EEG with epileptic or slow wave activity involving temporal lobes, or CSF pleocytosis, and reasonable exclusion of the alternative causes. Now, autoantibody detection is also sometimes difficult because of the various techniques available. And secondly, half of all autoimmune encephalitis series are antibody negative cases. So sometimes we may not be able to find the autoantibodies which is known. So that's why it is important to keep in mind that if there is such patient in which autoimmune antibody test is negative, we should always send the samples to the research lab. So 3 basic research techniques are usually used for this purpose: tissue-based assay, which is usually a screening test, then cell-based assay, and immunoprecipitation. Sorry. So usually whenever there is a sample of serum or CSF, usually autoimmune screening is done for all antibodies. Then cell-based assay usually is good for autoimmune synaptic antibodies, that is the classical autoimmune encephalitis syndromes. And immunoblotting technique is used for the paraneoplastic antibody, which are intracellular antibodies. And sometimes even after doing all this, we may not be able to find the antibody. So in those cases, we should refer the samples to the research lab. Then in our case, which was discussed, we had used this criteria to predict the chances of having autoimmune encephalitis. So this is one score, AP2 score, in which there are various points for new onset progressive mental status changes, neuropsychiatric agitation, aggression, liability, autonomic dysfunction, viral prodrome, facio-brachial dystonic seizures, facial dyskinesia, seizures if they are refractory to more than 2 anti-epileptic drugs, CSF proteins if they show more than 50 proteins and more than 5 cells, brain MRI suggestive encephalitis, or systemic cancer within 5 years. So if the score was more than 4, then it is 99% sensitive and 93% specific in predicting the neuronal specific antibody positivity. Always all these patients should be screened for neoplasia, and most common we should always screen for lung carcinoma, thymoma and breast carcinoma. In NMDA receptor, when it is positive, we should always screen for ovarian teratoma. MRI of the pelvis also may be done in some occasions. When antibodies are directed against metachromotropic glue receptor, then lymphoma should be searched for. Whole body PET CT is superior to CT alone. Pelvic ultrasound and MRI for ovarian teratoma. And if you are not able to find such tumor, then you have to repeat every 6 months until up to 4 years. I'll be just discussing 2 of this encephalitis in detail. So NMDA receptor encephalitis, it was described in 2005 by Delma and colleagues. The target is GLU-N1 NR1 subunit, which has role in synaptic plasticity, learning and memory. More common in females, but there is a wide range. Can occur or overlap with many other infections and some other autoimmune condition. Especially, I put a note that it can be associated with other demyelinating disorder like NMO spectrum disorders. They can relapse in 12 to 25% of patients. In 15% of the patients, antibodies may not be detected in serum. So always it is better to send the antibody in the CSF also. Tumor association can be seen in 10 to 50% of patients. So the usual progression of patient in a typical NMDA receptor encephalitis is initially there is a viral prodrome, they're followed by psychiatric symptoms like delusions, hallucinations, mania, agitation, speech disorganization, often seizures. And after that, weeks to months later, they can have neurological complications with particular movement disorders. And thereafter, after treatment or without treatment, they can be left with prolonged deficits. I'll just put 1 or 2 videos. This was a young female who was NMDA receptor antibody positive. She had this typical oromandibular dyskinesia. In her case also, there was no ovarian teratoma found, but then she responded to immunotherapy. This is another female in which there are emotional lability, different disorder. She was operated for ovarian teratoma. She also responded reasonably well to immunotherapy. Now coming to EEG and NMDA receptor encephalitis, it is abnormal in around 90% of patients. There can be non-convulsive status epilepticus, PLETs, non-specific slowing or extreme delta burst pattern. Now this delta burst pattern is defined as a EEG pattern characterized by delta activity of 1 to 3 hertz, superimposed burst of rhythmic 12 to 30 hertz activity. It is known as extreme delta brush because of its resemblance to the neonatal EEG pattern known as delta brush. Delta brushes are hallmark of EEG in premature infants, and they are key marker of neural maturation. Can be seen in benzodiazepines or barbiturate overdose. And if extreme delta brush is present in the appropriate clinical setting, then even with the suspicion, even if antibody results are negative, after excluding other causes, we can start immunotherapy. So just wanted to highlight that delta brush pattern which is seen in a typical patient of NMDA receptor encephalitis, and this is the normal EEG of a premature infant, which also shows the delta brush. So extreme delta brush is quite characteristic of NMDA receptor autoimmune encephalitis. Sometimes NMDA receptor encephalitis can follow herpes simplex encephalitis. So always we need to be aware of this particular syndrome, because in NMDA receptor encephalitis, after HSV encephalitis, the HSV PCR in the CSF becomes negative, and they do respond to the immunotherapy rather than the antiviral therapy. So always whenever patient come with the relapse of probably herpes simplex encephalitis, we need to work up for the NMDA receptor encephalitis. The second common encephalitis is LGI1 associated encephalitis, wide age range, common in males, can present with confusion, personality change, memory loss, seizures, faciobrachial dystonic seizures, and hyponatremia. The characteristic feature are these seizures and hyponatremia. MRI can be abnormal in 85% of patients with medial, temporal, and basal ganglia changes. It is paraneoplastic only in 11% of patients. So this is one of our patient from KEM, and I'll just play the video. So he had complex partial seizures since last 4 months, and disturbance of recent memory, and examination also showed significant impairment of the recent memory and frontal lobe release signs. CSF was acellular with elevated protein. The EEG was normal. Patient had this characteristic faciobrachial dystonic seizures. He had MRI abnormality of bilateral amygdala and hippocampi, and that's why we suspected autoimmune encephalitis in this patient, and anti-VGKC LGI1 was positive. So this is another of mine patient who had this. So sometimes this faciobrachial seizures can be slightly painful, and patient can have reactive pain. She also responded well to immunotherapy. So the other autoimmune encephalitis like Casper-2, it is common in males, usually associated with peripheral nerve hyperexcitability and commonly associated with thymoma. AMPA receptor antibody, which is common in females. Psychosis and seizures are one of the characteristic presentation, and they can have frequent relapses. GABA B receptor encephalitis usually also come with limbic encephalitis and seizures, and they can have association with neuroendocrine tumors. And GABA A receptor encephalitis, characteristically, whenever there is a prolonged status epilepticus, we should suspect this, and it can be associated with thymoma. Now, this metabiotropic blue receptor encephalitis can come with typical limbic encephalitis, confusion, and psychiatric symptoms. And it is associated with Hodgkin's lymphoma. So whenever there is association of Hodgkin's lymphoma along with this antibody, then we label it as Ophelia syndrome. Ophelia is a character in the Shakespeare drama Hamlet, and she is a young noblewoman, and she basically ends into a state of madness, and that's why this name comes from there. D2R receptor encephalitis is very rare. Only few of the patients have been described. DPPX characterized by GI symptoms, usually associated with B-cell neoplasm. GAD is usually associated with stiff-person syndrome, ataxia, and limbic encephalitis. Eglon5 can have a lot of sleep disturbance along with PSP-like presentation, which is well known. Neuraxin 3, again, it is very rare. At present, there is no cancer associated. So, coming to the management. So, as we discussed that the intracellular synaptic antigen or intracellular cytoplasmic or nuclear antigens, they are less responsive to immunotherapy. Whereas the surface antigen syndromes, they are more responsive to immunotherapy because these are antibody mediated. So the first line immunotherapy involves methylprednisolone, IV immunoglobulin or plasma exchange. The second line immunotherapy involves rituximab and cyclophosphamide. Alternative therapy can be tocilizumab or low dose interleukin. And in long-term maintenance, azathioprine and mycophenolate mofetil have been tried. As with many other disorders, we use only steroids, but why not steroid alone in autoimmune encephalitis? Because sometimes the difference between the autoimmune encephalitis and infectious encephalitis at the onset is difficult. And that's why many times the steroid initiation is delayed. Secondly, the reduction of the number of circulating B cell by glucocorticoid is much less than that of T cells. And the effect on serum antibody titer is also limited. So because it is largely antibody mediated disease pathogenesis, so it should be considered along with some other immunotherapy. So secondly, sometimes a steroid can complicate the psychiatric symptoms which are associated with such autoimmune encephalitis. So that also we need to be aware of. So after the initial therapy, maintenance therapy has to be given in some of the patient because it may not always be monophasic, and relapse has been known after many years. The relapse rate is around 10 to 20%. Long-term maintenance over therapy, especially in NMDA receptor encephalitis, is required at least for a specific population when there is overlap with other antibody syndromes or other T-cell mediated syndromes. Sustained use of oral corticosteroids or monthly IVIG of Plex for patient with incomplete recovery. Azathioprine and MMF can be used after acute treatment for sustained remission, but then long-term studies are not available. Intermittent administration of rituximab at 6 monthly interval or depending on the circulating B cell numbers may be considered as another option. And appropriate duration of maintenance therapy at present is currently unknown. Then there are few scores like NEO score, which is basically a combination of 5 criteria which predicts the functional score of a patient after 1 year. And there is another score called as RIGHT score, which includes the AP score along with the immunotherapy within 6 months of onset and neural membrane antibody positivity. And when the score is more than 7, it has good sensitivity and specificity for the favorable immunotherapy response. So in NMDA receptor encephalitis, the prognosis usually is good. Around 81% show complete recovery, and rest can have persistent cognitive or motor deficits. In VGKC encephalitis, almost all patients should show improvement. 33% may have persistent memory deficits, especially in LGI1. Thank you.
Thank you, Neeraj. I think Heli, can we go little extend the time? I think we are running little late. So thereby we have still Pankaj and myself, we have to still speak.
No issue, madam.
Okay. Yeah, Pankaj, go ahead.
This is the anniversary episode, so special.
Okay. Yeah. We had little glitch in the beginning. So
by what time we are expecting to finish that still?
I think by 9:30 we should be over.
That's fine. 9:30 is the usual time. So 9:35 is also fine. Don't worry.
Okay, fine. Yeah, Pankaj, go ahead.
Thank you, Dr. Sudhir Shah sir and Dr. Lakshmi for this kind invitation to the department. Dr. Rawat madam for kindly allowing me to be part of this seminar. I think you will agree that we have seen a wonderful case, and now I will provide some approach and insights into this young girl with chronic epilepsy and abnormal movements. And after that, also show you a little bit of overall and a small overview of movement disorders in autoimmune encephalitis. Of course, Neeraj has covered a large majority of autoimmune encephalitis in general. So as pertains this case first, so we know that she's a young girl and now she's 16 years old. She has had 2 episodes. The first episode was with seizure and then it got better. So probably immune encephalitis, Dr. Shruti was saying. And now the second after a long period of 11 years where she gets seizures and also movement disorders in this second episode. And as was highlighted very beautifully and shown in the videos, it was a lot of dyskinesia, including chorea, stereotypy of the mouth region, of the hands and in the limbs. And in addition, there was this very unusual feature, which of course was quite highlighted, and Dr. Akash showed that separately. And these were rotatory or gyratory seizures. And you heard Dr. Shruti saying that it was naturally wondered whether these are stereotypy, given that stereotypy is such a common part of NMDA encephalitis. And indeed, it can be very difficult to differentiate between epilepsy and movement disorder. It's especially in NMDA. And actually, even world experts, as you will see in the next slides, are sometimes confused as to whether particular movements represent what type of movement disorder, whether they represent epilepsy. So in the published article that was shown, it is suggested by the reviewers who reviewed that article that there was some equipoise between epilepsy and movement disorder. But I think, as Dr. Shruti said, it was more a little bit towards epilepsy. So I think overall, just commenting on the case very quickly. So whenever, for the young people who are listening over here, students, so whenever you have a young person, especially a female, and remember, female is important for NMDA, the ratio of female to male is 8:1 in NMDA. It is so strong in favor of females. If you have a young person, especially a female, keeping in mind NMDA, who has a mixed epilepsy and movement disorder of sudden onset or abrupt onset, and especially if psychiatric features precede, for example, the epilepsy or abnormal behavior, and this is acute subacute syndrome, there is rapid progression over a days or week. Often these patients become very bad very quickly, and therefore you have to really raise your level of immunosuppression and treatment very rapidly, as has been highlighted. The movement disorder is often chorea and stereotypy, often affecting the face. So orofacial stereotypy and chorea is typical, and it can often be in the limbs as well. One important thing is that these patients are often altered, and it has been referred to as status dissociatus in NMDA, where the girl, for example, will be in a state partly between awake and sleep. So all these features should make you think of NMDA encephalitis. And now when we look at this in retrospect, it is quite clear that this girl had NMDA. But I think these are the important principles that young neurologists should remember. These are immediately should make you suspect NMDA. Now, here in this case, we saw delta brush, serum NMDA was positive, even CSF was positive. Remember that one important point, that CSF can be positive only in 15% cases with negative serum. So if serum is negative, definitely do CSF NMDA. Here the diagnosis was made. I think this case overall is remarkable for two unusual features in my opinion. Now, one is these gyratory seizures, which have not been described in NMDA. So it's actually a fantastic pick by our department and Dr. Akash, who was the first author on that article. It is a fantastic description of gyratory seizures in NMDA, and they can be mistaken as part of dyskinesia of NMDA. We'll get into that in the next slide. And of course, the second important point, which is very remarkable, is that there is a long interval of 11 years. It's very unusual because even in the literature we saw, it was only around 6 years is the maximum that has been described. But actually, one must also remember that NMDA was only described in 2007. And relatively, we are still, we don't know too much about NMDA. It's not like a 50-year-old disease. So therefore, the long-term behavior of NMDA is unknown. And maybe as time goes on, there will be more literature reports of a longer interval of relapse in NMDA. So this case was remarkable for these two very different features. And therefore, I really believe this is a unique case. And this was also shown in our MDSI webinar. But I think the way it has been dissected and analyzed today has really done justice to this case. Now, I think there was talk about stereotypy. And let us discuss a little bit about stereotypy from the movement disorders angle. So just forgetting NMDA for a minute, what is stereotypy? So Edwards and Bhatia defined stereotypy as a single movement pattern, and this is in 2012, very important definition. So every point is important, so just pay attention. So it has to be a single movement pattern, which can involve a number of muscles, but single movement pattern. It has to be purposeless or non-goal directed movement, which is repeated continuously for a period of time, often hours, on multiple occasions. And it has a looping character, as if the video is put on loop. And so somebody has put the video on loop and forgotten. So, the whole thing keeps playing again and again and again. And that is characteristic of stereotypy. It is distractible. This is a very important feature. So the patient is aware and alert completely. He's just performing the movement. And when you distract the patient, the stereotypy will stop for a few seconds. And when the distraction goes away, the stereotypy restarts. So this is very classic of stereotypy. So I just thought I'll take the liberty of showing you this case. So this is a fantastic case again from KEM, our department, where we published this man with Wilson disease having purposeless and repetitive finger flexion. So look at this movement, and this is the way he had presented to us. And I remember Dr. Rawat had asked me that, Pankaj, please characterize this movement. And I really was not able to immediately when I saw it. But actually, if you see, it fulfills the definition of what I just showed you for stereotypy. So it is a movement as if it is being put on videotape. He just performs this one pattern and nothing else. So when this pattern occurs, one pattern at the expense of all other motor output, it is totally dominated by this movement, his motor output, this man's. So, and it is going on as if on loop for hours and hours. He would keep doing this. And when somebody would start talking and he was distracted, it would stop, which is another very important feature of stereotypy. So he had all the features, this movement of stereotypy, and the interesting thing is that it was a presenting feature of this man's Wilson's disease. So when he performs some other hand movements, for example, it stops, and when he is distracted, it stops, and as the distraction goes away, it reappears. So therefore, if we apply these to today's case, in today's case, this woman had these round and round episodes of rotation. So you can say that that was a single movement pattern. You can say that it was purposeless. Certainly going around and round in circles is purposeless. But you can't say that it was happening for a period of hours because it was only for a few minutes. So this is a very important point, which is again stereotypy in this patient of today. So it was on multiple occasions, of course. It had a looping character because she was going around in circles. So, it was certainly the same movement as if on loop. It was not distractible. And in fact, this patient was not maintaining her awareness. She was not alert. She was altered, which is the biggest feature in favor of a seizure or a gyratory seizure. And of course, she also had the abnormal EEG with the delta gush on the contralateral side. So three major points which tell you that it was not stereotypy, but seizure. So fully agree with Dr. Akash's analysis, Dr. Shruti's, and although we can debate, and certainly in that journal, the reviewer debated whether it is stereotypy or seizure. So I believe that it was a rotatory seizure and not a stereotypy, and I've shown you why. So let us look at stereotypy. Typically what happens in NMDA. So stereotypy of NMDA is focal, usually affecting the mouth and orofacial region and jaw. Hand and shoulder may be affected. It can go on for a period of time, sometimes on multiple occasions. And all these other features are common. But one important difference is that patient awareness and alertness may be altered in NMDA. So that is just something to remember. So as I said, final diagnosis, at least for me, for this case, for that movement is a seizure, not a stereotypy, not a movement disorder. But actually, if we consider the proposed origins of gyratory, as Dr. Akash has so nicely shown, strong involvement of basal ganglia is present, and actually it originates, even the gyratory seizure originates from the basal ganglia. So certainly there is some overlap between seizure and movement disorder, and hence the ongoing debate. So I think with that there is not much time, so maybe in 5 or 7 minutes I will move out of the case and just try to show you how autoimmune encephalitis can get involved in producing movement disorders. So we must remember that movement disorders are common in autoimmune encephalitis. They are often accompanied by cognitive decline and seizures. And we know that autoimmune encephalitis occurs across ages. It is an important acquired treatable cause, therefore not to be missed. And it is increasingly important to recognize movement disorder patterns as autoimmune because of this very reason. And therefore we should learn the common patterns and presentations of movement disorders in autoimmune encephalitis. So recognition of the clinical approach will guide diagnostic workup in autoimmune disease, and paying attention to age and gender and the phenotype, whether it is isolated or combined, the movement disorder and red flags. This will all help us in coming to our diagnosis. So starting with chorea or dyskinesia. So acquired chorea is frequently autoimmune. In fact, chorea is the #1 in autoimmune movement disorder. Okay, so Sydenham's chorea, Apla syndrome, and of course neuronal antibody associated, all have chorea. In neuronal antibody, the typical example, of course, is NMDA encephalitis, and LGI1 also can have chorea. Caspr2 can have chorea. Urexin 3 is a rare example that can have chorea. It mimics NMDA. And Dr. Neeraj had said that in children, you have this D2R antibody encephalitis that can have chorea and tics. Paraneoplastic, of course, we know, we have heard, so I will not go into that. This is just an example of a boy with Sydenham's chorea. So you can see typical, so Sydenham's chorea is a prototype of immune chorea. Apla syndrome is another example, and NMDA, of course, the whole focus today was on NMDA. And I'm not going to go into all the details on these slides because I think Dr. Neeraj has shown that already. I will just say that the typical presentation of NMDA, as has been said again and again, is a psychiatric manifestation, seizures. Catatonia is a very important feature, and that was also highlighted. Catatonic posturing in NMDA. Dyskinesia, orofacial, chorioathetoid, and of course, a lot of them, like this lady, also had autonomic instability and language dysfunction, which this lady also had in her earlier presentation. So all these features can be seen in NMDA. So just to show you some typical examples, a few more. So you see this young woman with a 2-week history of these typical symptoms, which are on the slide. And you can see that she has orofacial stereotypy. She has hand stereotypy. Okay, so just to show you that stereotypy, often mixed in with chorea, can be seen in various body parts. And this lady completely improved with appropriate treatment. So extremely and eminently treatable. This is another girl. And again, you look at her movements and you will see that she does have the mouth and lips. See, that is so common, the mouth and lip. But also the shoulder stereotypy. So look at the shoulder stereotypy. So the same movement of the shoulder keeps occurring, and there is also some leg movement. So stereotypy and chorea will predominate, and this lady is altered and drowsy, and these stereotypies are occurring in a drowsy sort of state. So these are all typical of NMDA, and look at the mouth and the face, and she is also in between sleep and awake. So sometimes they are in status dissociatus. So that is associated. So very interestingly, the distinctive movement disorder of NMDA is extremely difficult to characterize. In fact, it has been repeatedly emphasized that if you have great difficulty in characterizing a movement disorder, that is typical of NMDA. But it is highly distinctive, and only by looking at these videos of classic examples can we familiarize ourselves. That's why we have shown you all these. So highly distinctive chorioathetoid and stereotypic movements. Paucity of tremor and myoclonus. So tremor and myoclonus is very, very less common in NMDA, and catatonic posturing, of course, can be seen. So another example, one typical feature in this girl. So in this girl, again, you see that she's altered, but you can look at her eyes. So she is getting actually oculogyric crisis, which of course is a focal dystonia and goes on for very long in this lady. And she's actually the same girl, the second girl. And oculogyric crisis is also well described in NMDA. And in this girl also you see complex bilateral stereotypic hand and arm movements, and perioral and eye movements also a little later, and less frequent leg involvement. So all these features are seen in these young women with NMDA. So very classic. And status dissociatus is a state of paradoxical responsiveness, and it's seen in various other, but just remember that in NMDA as well. And again, the classic delta brush of the lady completely improved by treatment. Again, some other small examples, and you can see again this. So always they are young women, and look at the mouth. So chorea and stereotypy of the mouth and face. So several examples to show you. I think we are out of time. I will just skip this slide. This is a wonderful movie and a book called Brain on Fire. And if you have not seen this, you must see this to understand NMDA. This is for the young people. I think I will skip evaluation and treatment of NMDA encephalitis, already been covered by Dr. Neeraj. And I will just make some remarks on autoimmune dystonia. So oculogyric crisis is one that we have shown you. Hemidystonia, craniocervical dystonia can be rarely seen in NMDA encephalitis. Jaw dystonia and episodic laryngospasm should make you think of anti-Re paraneoplastic encephalitis. And lockjaw or tetanus type is seen in glycine receptor antibody. So remember these phenotypes with these antibodies. Now LGI1 encephalitis is a classic prototype of autoimmune paroxysmal dyskinesia, and Dr. Neeraj has shown you already FBDS. So this patient I will not show, but I will just show you some classic for those who have not seen, maybe the younger people, classic examples from the literature of faciobrachial dystonic seizure. So a sudden jerk of the left arm and the left face in this lady, you see right there. It's very sudden and lasts for 1 or 2 seconds. One of the most important things is that these are very brief attacks and they are always less than 1 or 2, maximum 3 seconds. So this is a very, very important feature of FBDS or faciobrachial dystonic seizures, which are highly characteristic of LGI1 encephalitis. And sometimes they may be occurring on alternate sides of the face. Sometimes they may involve the leg and the patient may just come with falling. So all these variations. This is also Dr. Rawat's patient. And this is a woman where you see, this is from the literature. You can see that it's one side and then it alternates, and you can see it on the other side as well. So this is on the left, and again you will see an FBDS on the right in this lady. Okay, so again there is debate whether FBDS represents movement disorder or epilepsy. I will not get into that. And autoimmune myoclonus is again autoimmune encephalitis. LGI1 is an encephalitis which classically causes autoimmune myoclonus, because the FBDS is is like myoclonus, but of course it is different. I think we have already covered this. One example of an autoimmune disease causing a paroxysmal dyskinesia is painful tonic spasm, as you see in this lady with neuromyelitis optica, and she has a large lesion in her cervical cord and she has severe pain. Whenever you have pain with such dystonic posturing, you should think of a tonic spasm of demyelination, because dystonia usually will not have so much pain. So this is aquaporin 4 disease with painful tonic spasm. Autoimmune Parkinsonism, don't have any videos, but you should remember that CRMP5 can cause chorea and Parkinsonism. Anti-Re encephalitis can cause dystonia of the jaw and Parkinsonism. MATU encephalitis can cause PSP-like Parkinsonism. And there are some non-paraneoplastic examples of these various antibodies, which can, so Parkinsonism can be very well a part of an autoimmune syndrome. Stiff person, I think Dr. Neeraj has already spoken about. I will not go into, and cerebral ataxia also he has, so I will skip. Neuromyotonia is a very classic phenotype of Casper2, but sometimes seen in LGI1. So this phenotype should immediately make you think of an autoimmune disease. And tic and tremor are uncommon, so I will skip. RBD can be autoimmune in various syndromes, so just keep that in mind as well. So for example, MATU encephalitis can cause RBD, Eglon5, LGI1, all these can also cause RBD because it's from brainstem involvement. I think I will skip this. This is a very important slide, and if you want to take home, remember this slide in a beautiful article by Balint and Bhatia in Brain in 2017, which is a classic, which is an iconic landmark article which you all should read. And this lays out the pathophysiology of all these syndromes, and the neuronal surface ones are extremely and eminently treatable and responsive, whereas the paraneoplastic ones on the right side, they have a strong tumor association and are not responsive to treatment, and the intracellular synaptic ones like GAD are in between. So I think that you should read. Yeah, I think so. Just to close, I think remember the association of the movement disorder and the antibody and various movement disorder associations. There are 3 types of antibodies: neuronal surface and synaptic and intracellular. But the most common are the NMDA LGI1 as part of the neuronal surface antibody disease. And early recognition clinically is extremely important. Therefore, all this emphasis on recognizing these patterns, because the antibody associations can be easily identified. And of course, this has a strong bearing on treatment. So I think with that, I will stop. Thank you.
Yeah, it was an excellent discussion, and we are going in a very, very deep understanding of the autoimmune encephalitis spectrum. And I think now it is turn of Professor Head, Dr. Sangeeta Rawat.
Yeah, thank you, Sudhir Bhai, and thank you for allowing us to extend the time. Because we wanted to do some teaching also apart from only showing the case, as we are in a teaching institute.
No, that is the reason why we have started this series. So
Yes,
this is
yes.
an integral part of this whole webinar series.
Absolutely. Thank you. So now we have seen that the case has been highlighted very well and has been dissected. And also there is that I also want to show that it also involves, there are some other points which we must remember. And this is that a seronegative autoimmune encephalitis. I think as the people are saying that this is the classic presentation, and then we go and do an antibody, and we don't find the antibody positive. So we are really stuck. What to do? Should we treat? Should we not treat? So and also in India, some of the antibodies are available, and there are many which are not yet available. So that is what I want to highlight today. I will start with the two cases. So there was this young boy, a young girl first. I will show a young girl who came, a 9-year-old with a normal birth and development history, no initial precipitating event, and she started with the seizures and behavioral changes since 1.5, since last 1.5 years, with multiple etiologies, 2 to 3 per week, and gradually it increased. When she came to us, she had almost every day. She also had a lot of aggressiveness, inattention, memory disturbances. She dropped in her scholastic performance. And we had similar, another boy of 11-year-old, born of non-consanguineous marriage, again normal birth and development. He had a fever for 4 days prior to the onset of seizures. Seizures and behavioral changes for last 1.5 years. And there was an aura of, he used to have focal motor unaware seizures, and he had a hissing sound as an aura. Seizures increased to 1 to 3 per week. He also had a behavioral changes. He dropped in scholastic performance. He had aggressiveness and irritability. Now, these are the two events. This is that girl who had this classical, she comes to know that she is having a seizure. She has an aura, which she's not able to describe to us what is the aura, but she will call the mother. She has an eye deviation, and then she calls the mother that she is getting a seizure. So the Ergi Ala, and see her speech has also become dysarthric. And then she starts having this, which looks like a hypermotor, partly looking more like a frontal lobe seizures. And she's not responding, but it starts frontal and going into the temporal. That's what the etiology. And then we have this another boy who has this right hand going into dystonia. So you can see he starts with dystonic posturing, and then he has this, figure of 4 sometimes, and the multiple symbologies, either frontal and things like that. Now this is the EEG of the girl. It's showing a multifocal epileptiform discharges with profound background slowing, and you can see the scattered spike and wave everywhere. And this is the EEG of that boy who has a seizure onset, and there is rhythmic ictal rhythm which is coming up more from the left and sometimes from the right. So with this clinical scenario, we went ahead and did the MRI. MRI of both the patients showed, the girl and the boy showed a left mesial temporal sclerosis. Definitely the clinical presentation, the behavioral changes and the EEG pattern did not match with the left mesial temporal sclerosis. So we went ahead and did the PET scan. Now we have a picture of the girl's PET scan which shows a left mesial and lateral temporal hypermetabolism. You can see here. Plus there is a hypermetabolism in the bilateral basal ganglia and right mesial temporal, which I don't have the cut currently. And the PET CT of the boy showed a large area of asymmetrically decreased FDG uptake within left medial and left lateral temporal cortex and left parietal cortex. So with this, we went ahead and did the serum testing and the CSF testing. And unfortunately, that girl has shown all negative, and the boy showed NMDA as strongly positive. Now, the clinical picture was similar, EEG was similar, MRI was similar, and also the PET was showing changes. So we treated both of these patients with app score, which Neeraj just said was 4 in both. EEG showed, I've already shown you the EEG, and though the antibody panel was negative, they both were uncontrolled in 4 ASM. We treated her also with steroid, AVIG, sorry. And seizures improved markedly. She has just been discharged last week. We have not yet given her rituximab due to the financial constraint. But if as the seizures are controlled, but the behavior has not yet improved. And this other boy also was treated with steroid, IVIG, and rituximab. Now both these cases were sent to us for a surgery. So this, I want to highlight that even though there is a left mesial temporal sclerosis, and the other boy was actually posted for surgery in other center, and the father decided to come here for second opinion. So even when we are seeing this temporal sclerosis, do not go and operate if the history is very short, if there are behavioral changes, if there is a EEG which shows abnormality. So in autoimmune encephalitis in California, they had a long series of encephalitis. They found that 30 to 40% of those signs and symptoms, when there is strongly suggestive, do not show the antibody after exhaustive testing. Also, now going on to some literature on the negative, seronegative, this Saraya et al. Had suspected 77 adult patients, autoimmunes, 4 were antibody negative. And Gross and all found 7% had antibody negative. But we have a proposed diagnostic criteria by Gross, and he says that there is a rapid progression, memory deficits, mental status altered, psychiatric symptoms, and you have ruled out Bickerstaff or limbic encephalitis or EDEM. The MRI is showing abnormality, CSF is showing a pleocytosis, and you may not have the brain biopsy. But it may show if you are doing, and you are reasonably excluded other, then you must think of autoimmune encephalitis as or seronegative autoimmune encephalitis. And the Gross studied that he had 12 out of 163 patients. Mean age was 62 years, and the most frequent initial symptoms in the seronegative patients were short-term memory leading to hospital admission in a few weeks. The patients had either lung, esophagus, or 4 patients had the cancers. CSF showed pleocytosis in 58%. The immunotherapy included steroids, IVIG, and in some patients rituximab. And according to him, 54% showed a good reasonable outcome. So even if the antibody is negative, you must start with the immunoglobulins on followed by rituximab if required. Another one which is done by Sunil Pradhan from India. Now he had 32 cases, and out of 31 cases, out of the 16 patients were positive, and then we had 15 patients who were antibody negative. And he found there was no difference in the seizure, behavioral abnormality, dementia, and alters in between the two groups, antibody positive and negative. And there was a complete or partial response in both of them. CSF was slightly more positive in the definite group rather than the antibody negative group. And malignancy was found in 2 patients in definite and 1 patient in antibody negative group. So if you want to think about this, whenever there is a presentation of rapidly evolving working memory deficit, confusion, mood changes, psychiatric symptoms, and new onset seizures or a movement disorder, always think of autoimmune encephalitis. And autoimmune epilepsy also you should think if it is a new onset, but as we have shown that in our case, it is a chronic epilepsy patient, but it showed that there was a quiescent period of 11 years. Whether there was in the childhood she had a herpes encephalitis and now she had an NMDA, or it was NMDA in the childhood also and now also there was an NMDA, we still can't say because we did not have any NMDA receptor antibody possible at the age of 5 years. So if they have a multiple seizure types or they come with a NORS or fires and there is ASM resistance, then you must think of autoimmune epilepsy. EEG, as I think Neeraj has already said, extreme delta burst you may also have, but that is seen only in 30% of the cases. So even if the EEG is not showing, you can still think of autoimmune encephalitis. LGI1 may just show a focal, frontal or temporal slowing, multifocal epilepsy from focal discharges, multifocal slow wave activity, and the background attenuation. Ictal EEG by and large in FBDs is by the muscle artifact, but it may show a rhythmic delta activity. Now in antibody negative patients, EEG abnormalities are also common, and in Pradhan's series, the EEG was abnormal in 81% of antibody positive and 86% of antibody negative patients. And in the gross, almost 83% patients had either focal or diffuse slowing without any associated epileptiform discharges. So even if the EEG just shows slowing, it is in favor of an autoimmune. And then there comes the PET CT, which is now definitely much more positive. In whenever MRI is normal, in a series of Solons by et al., 23 patients with antibody negative, 43% had abnormal MRI, but 95% had a PET CT abnormality. So if you are strongly suspecting, please go ahead and do the PET CT. It may show hypo and as well as hypermetabolism. So basal ganglia may show hypermetabolism and temporal lobe may show hypometabolism. And even in a pediatric cases, there was a series of 6 cases where the PET CT was abnormal in all of these cases. Antibody-specific PET CT patterns are still emerging, but in LGI1, it is said that already mesial, temporal and frontal hypometabolism with basal ganglion, midbrain and cerebellum hypermetabolism. PET CT helps in identifying areas which are not involved in MRI, and that's why it gives better correlation with clinical symptoms, and it can also predict the disease activity status better. So even in follow-up, you can use the PET CT. Treatment response between antibody positive and negative is not much different, but though our personal experience in a short case series is feel that antibody positives have a slightly better response. Steroid and IVIG and rituximab are the mainstay, and response is comparable in Pradhan's group. 66% showed a complete response and 33% had partial response. In Gross, I already said 54% had a positive response. So the trial of immunotherapy has to be given in a suspected case of autoimmune epilepsy. And also so now I will go over to the next important part is the pediatric autoimmune epilepsy. Though majority of us are adult, but nowadays we also see the pediatrics. So there are 2 peaks which can occur. Is NMDA usually occurs in the pediatrics more at around the 1st and 2nd decade, and followed by LGI1, which is more in the elderly, that is 60 to 69 group. So what is the difference in the pediatric? Currently, the most common antibodies in the pediatric are NMDA, MOG and GAD65. And important thing is they cannot describe their symptoms. So they only have a behavioral changes. They may have an atypical presentation, and there is a limitation that we cannot do a neuropsychological evaluation. 50% may have a prodromal symptoms of fever. And between the disease onset and initiation of therapy, symptoms typically persist over time. Whereas, if there are you have to distinguish from PANDAS or PANS, which is a relaxing remitting course with rapid progression to maximum symptom and rapid return to previous function. Whereas in the autoimmune encephalitis, they continue to have symptoms and they do not remit unless you are treated with it. And what is the difference between adult and pediatric? The new onset psychosis in children younger than 13 years is uncommon and considered as a red flag. A typical presentation occurred to, now this is why the children are different, because due to evolution of the neuronal circuit are still evaluating, they are still forming, neuroreceptor densities are different, myelination is different at different age, and this causes multifocal neuropsychiatric symptoms rather than isolated clinical syndrome. So the syndrome based approach which we can use for the adult, we may not be able to use for children. So children with GAD65 may not present with a classical stiff person or cerebellar as seen in but they may present with other group. Children with NT-NMD are also likely to present with movement disorder and agitation, which I think Akash showed one girl, and insomnia, seizures, rather than they may not present with a memory deficit, psychiatric manifestation as seen in adults. Seizures also present, common presentation in children, and language loss and speech impairment can be a presenting feature, which was seen in our case at 5 years of age. She had a language loss. So probably she was having an NMDA encephalitis even at the 5 years of age. So pediatric autoimmune is less associated with tumors, definitely compared to adults. So this was a very nice paper. And here they said that CNS infection, metabolic disorders and mitochondrial disorders need to be specially considered as in a suspected case of pediatric autoimmune, and EEG may be more helpful. Pediatric patients also should generalize EEG abnormalities compared to the adults, which show frontal and focal temporal using, and EEG helps in differentiating psychiatric. You have a psychiatric disorder and behavioral disorders, EEG may be normal. And neurocognitive testing wherever possible you must do. In a series by Lee et al. Of 46 cases, they had 37 patients were of an autoantibody negative, and they found that primary immunotherapy, that is only steroid, were enough to treat, and they did not require a second line treatment. And in India, a series of 9 pediatric cases with abnormal behavior seizures were followed by autonomic dysfunction were also seen, described from India also. So I think it is important that autoimmune antibody negative in pediatric also does exist. So if you have a clinical scenario of movement disorder with seizures, you must, with a recent onset, must think of treating them as autoimmune encephalitis. And lastly, outcomes. In a series of 120 patients, the mechanical ventilation was required in 57% of cases, and the median duration was 28 days. 37% had to be reintubated, 61 underwent tracheostomy, 47% had a MRS of 4 or more at discharge, and however 50% did show improvement. So in an autoimmune, mechanical ventilation, sepsis, autonomic dysregulation appear to indicate a longer and incomplete convalescence, and classic ICU complications better serve as a prognosis. That's why we lost our patient in ICU complication of Webb. I think Neeraj has already shown this, but I only want to show this. When you are doing this tissue-based, this is a tissue-based thing, and if you, this is the negative, but if you have an something like this, then it is a positive thing, but we do not know the antibody. So when you do this with mouse tissue-based and you mix the CSF or serum of the patient, and if you find this, then it suggests that there is an antibody which is there, but you do not know which is the antibody. And then you can further confirm this reaction by mixing them with the neuronal cells. And if you find this type of pattern, then you know it is an antibody, which is, but it is a new antibody, not a known antibody, but it is an antibody mediated response. And I think Neeraj has already shown this. So if you have this autoimmune screening, then a cell-based should be followed, and you may find this positivity. So it is an evolving branch, and I think we have today the best day that we are having a book from our Indian author on this. So it started in 1980 with IVIG for immune disease, and then we have a classic onconeural, and after 2000, in last 10 years, we have multiple autoimmune, the antibodies which are coming up. But it is important that they are potentially treatable entity, and as neurologists, I think we are very happy if there is something treatable. And it is extremely important to recognize this clinical entity, diagnose it ASAP, so that we can investigate and treat them definitely better. Earlier we start the treatment, better is the reason. And I think all of you should have this, table in your mind, where if you have a clinical presentation, where you should fit in and which antibodies you should change. So to conclude, important thing is that clinical course is often very prolonged, may require long ICU stays. So the patience is required by the neurologist as well as the family. So it is important that as soon as they are diagnosed, tell them that you have to be ultimate, the result may be good. So you have to continue for months together with us, and the family and relatives have to be consent regarding this. Do the serum and CSF to a research laboratory if strongly suspected, and cancer screening should not be forgotten. So these are the references which I have used, and thank you very much.
Thank you, Dr. Sangeeta. Dr. Lakshmi, would you be giving some comments? But before that, I may add some lines, because first of all, I must congratulate Dr. Sangeeta and the whole team for a wonderful exposition of the subject, nice dissection of the case, and extensive review of the subject from different angles. Wonderful. Thank you so much. I'm sure all high yield centers in India have similar experience in NMDR, and so we also have odd number of about 21 or 22 cases of NMD1 encephalitis. And I can tell you that this is a monster with many faces, and unless you recognize all those faces, we are going to miss and delay the diagnosis. And if that happens, then it's very difficult and sometimes life-taking disease. We have seen all different manifestations right from Korea to whatnot, but I must add that we had a elderly patient who had NMDR encephalitis who presented with dementia. I had a middle-aged woman who came with faciobrachial dystonia, and she had NMDR encephalitis. We had anemomyelitis kind of presentation with NMDR positive, and she had teratoma. So I think it's a great learning, and I don't think that we have finished the learning curve as far as the autoimmune encephalitis is concerned. And there are a lot of confounding things, and whether it is epilepsy or it's a movement disorder, or I'm fond of calling it epileptic movement disorder, something like that. And I think treatment part is also discussed very well. But I would have asked Pankaj, but for the lack of time, I mean, what exactly do you give for those orofacial dyskinesia which are refractory? I mean, they don't respond to your IV immunoglobulins or plasma, etc. Till that time, to prevent a lot of damage to mouth, teeth, etc. I mean, what are the drugs that you favor? We have been trying lacosamide, topiramate, and some other stuff, but I mean, what is your favor? Madam, you or Pankaj may suggest that.
Yeah, Pankaj, go ahead.
No, sir. Yeah, so you're right, sir. There is nothing really, I mean, they don't respond to anti-epileptic so much, as you have said rightly. So really, I mean, if they are extremely bad, then you will be forced to sometimes use a strong antipsychotic, but those are just exceptions. But they are very poor to respond to anything, and ultimately just treating with immunotherapy and hoping that the movements will decrease. So really, there is no good pharmacological treatment.
With the permission of the chair, sir, I have tried intractable.
Last one line before I close. The patient which I was talking had actually intrathoracic teratoma ultimately discovered on PET scan, and we removed that, and after that she got all right. Lakshmi, please go ahead.
No, the plasmapheresis also helps, sir. When it is
yes,
in our setup, we can't afford for IVIG everything, but we have a very good. Our residents are good in doing plasmapheresis, so we do for every refractory case, even IVIG refractory, we get good results with comparably good results with plasmapheresis in most of the autoimmune.
I agree. I think given the seizures as well as the movement disorder, they both respond to immunotherapy rather than the anti-seizure medication or antipsychotic, I think.
And
no, I said the same word, ma'am.
Yes.
That till the immunotherapy works, till plasma exchange or IV gamma, sometimes it takes long time.
Yeah, absolutely. I agree. That's what I said. You really have to be patient,
And
during that time, we have to do something for
something. I agree, definitely.
Sir, and sir, as a concluding, and I should really thank Professor Sangeeta Rawat and her team for choosing a most appropriate lecture at the launch of my book.
Yes, absolutely.
Even if it is so unplanned, and everything what you have talked, we have written on the book. So it's a great pleasure that most of the topics, it's God's coincidence that I was able to get the entire coverage talk by the top people in each field in Mumbai, so that it was in fact I was very happy with the every talk when I listened, and it was the most appropriate theme for the launch of my book. I can't ask for more.
Yes.
Thank
Yeah,
you
even
so
I was
much for
happy to see that, you had written a book on the neuroimmunology and our case was the same, the whole topic
I was
was
very,
same.
very happy about that. And I thank every one of them.
I hope you
Dr.
found
Pankaj, Dr. Rishikesh, Dr. Shruti.
our scientific thing was up to your level.
No, it's all great. I tell you, there's so many feedback they already called and told that it's all exam time. And there is no paper without autoimmune at all. So the boys are all glued to the thing because the entire spectra you have covered, and they can't ask for more than this in 1 hour and 15 minutes. It's a very good revision for them in the exam, and they are straight away the exams everywhere. The exams have started. So, so it's a most appropriate thing, and I thank the entire team, Dr. Rishikesh, Dr. Pankaj, Dr. Shruti, Dr. Sangeeta Rawat, and every one of you. My hearty Dr. Manoj and all of them, I thank, and the INTAS team also I thank heartily. And before we wind up August 29th, we will be shifting our venue to Bengaluru, Vaidehi Medical College. Dr. Suresh Kormala and Dr. Nataraju, Bengaluru, Dr. Nataraju will take over the scenario, Vaidehi Medical College, Bengaluru, from Mumbai to Bengaluru. We fly off to Mumbai to Bengaluru, and last Sunday, 8 o'clock, we meet again. Thank you so much. Thanks for every one of you. Yes, sir.
And thank you very much, Sudhir Bhai and Lakshmi, for inviting my department to participate in this. I really enjoyed it.
Thank you. It was a very wise decision, and you proved it correct. We are very much grateful to the whole team.
Entire team. Thank you so much, man. Thank you for sharing your time.
We are forgetting one thing. There are so many attendees, more than 300, and you have come up with the book. So are you going to be grateful?
To give 300 free copies.
Are you going to distribute your book to those or not?
Sir, you should announce it, sir. You should be. I think I'm very thankful that Dr. Mr. Arun Chadda has agreed to distribute to all the participants of the neurology speakers, and I really want to give a big hand for their kind gesture by INTAS that all the participants and all the residents across the country who participate in the neurological speakers will get the book delivered at their doorsteps by the INTAS network. And I am myself, Dr. Mukundan, Professor Mukundan, and Professor Rajesh Shankar Iyer. All the three of us are grateful for your kind educational gesture in distributing the book. Thank you so much, sir. Thank you.
Thank you, sir.
Thank you.
Thank you.
Your all hard work that is paying off. Mr. Chadda, please.
Thank you.
Thank you. Today, sir, it's an auspicious day as there was unveiling of the great book, monograph, Immune-Mediated Neurology Disorders, edited by Dr. Lakshmi Narasimhan sir, Dr. Mukundan sir, Dr. Rajesh Shankar sir, and my heartiest congratulations to Dr. Lakshmi sir, Dr. Mukundan sir, and Dr. Rajesh sir for this beautiful book, which will be helpful to all the DM and DNB students across the country. Further to this, today it was anniversary special episode of Secrets of Neurology web series, which is the longest web series till date. It turned out to be very successful with more than 300 plus delegates who make this episode memorable. And I, Arun Chadda, Senior General Manager, on behalf of INTAS Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence, and its audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to congratulate and thank our Honorable Course Director, Dr. Lakshmi Narasimhan sir, and Dr. Sudhir Shah sir for this longest web series, which they have designed in such a fantastic way on neurological case studies, which will be very helpful to all the DM and DNB students. And I would like to thank to our young neurologist, Dr. Rishikesh Joshi, for presenting the excellent and unique case. Further to this, I would like to thank the entire KEM Mumbai neurology team, Dr. Shruti Agarwal, Dr. Akash Chheda, Dr. Neeraj Jain, Dr. Pankaj Agarwal sir, and Dr. Sangeeta Rawat ma'am has given their excellent expert comments for such a unique cases with fabulous presentation. The entire presentation will be extremely helpful and informative to all the participants. And in the last, as Lakshmi sir has already communicated, the copy of the book will be shared with all the participants, those who have participated today. And once again, thank you for your gracious presence. And it's being a pleasure being with all of you today. Thank you all your patience, and I wish you all a very good night now, with the promise that on 29th August, because now we have shifted from Friday to Sunday. So it's 29th August, we will meet with yet another most awaited session, the next Secret of Neurology. Till then, stay safe and
It is only Friday, sir. It is only Friday. My date is wrong. I just checked.
Okay. Okay,
it is
so
only
sorry.
Last Friday. Last Friday.
Yeah, it is.
request
Then it is 27th of the last.
Yeah,
that is
27th.
27th
No
August.
change in Sunday. It is 27th
Okay,
of
okay.
Friday only. No change. I'm sorry.
So
I
sorry.
thought it is 27. I saw in my mobile it looked like 27.
Before
Yeah.
you close, I think Dr. Pankaj wants to say something. Dear Pankaj.
Yeah, no, I just had one request that I request that the copies which you are sending us, that they should be personally signed by you.
Definitely. It will
Because
be,
we have helped in unveiling your book today.
It is my great pleasure, sir. I will definitely do it. Thank you. Thank you.
Thank you.
definitely.
Okay.
Thank you, sir.
very
Thank you very much. Thank you, ma'am.
Yeah. Thank you very much, Dr.
Thank
Mr.
you.
Chadda, and thank you, Heli.
Thank
for,
you, ma'am.
Thank
yeah,
you.
yeah, for
Thank you.
arranging all this. I think.
Thank you,
Okay.
ma'am.
Yeah.
Thank you, sirs.
Grateful
Thank
to
you,
all
ma'am.
of you. Grateful. Lakshmi,
Thank you.
specifically, congrats to you once again. Thank you.
Thank you.
Thank
Thank you,
Thank you,
sir.
Sangeeta and team.
Thank you.
Yeah.
Great. Thank you, everybody.